Today we are covering type 1 diabetes mellitus, focusing on what you absolutely must know for the NCLEX. The exam will test your understanding that this is an autoimmune disorder where the body's own T cells attack and destroy the pancreatic beta cells, leading to an absolute deficiency of insulin. Do not confuse this with type 2 diabetes, where the primary issue is insulin resistance. A classic exam question will present a newly diagnosed adolescent patient with significant weight loss despite increased appetite, and you'll need to identify the pathophysiology as autoimmune destruction. The hallmark signs you'll see in a question stem are the 3 Ps: polyuria, polydipsia, and polyphagia, along with fatigue and unexplained weight loss. For diagnosis, know the numbers cold: an A1c of 6.5% or higher, a fasting plasma glucose of 126 milligrams per deciliter or higher, or a random glucose over 200 with symptoms. Since the body produces no insulin, treatment is lifelong exogenous insulin therapy. The exam loves to test insulin safety. Remember that long-acting insulins, like glargine or Detemmer, must never be mixed in the same syringe with any other insulin. For insulins that can be mixed, like NPH and regular, the mnemonic is RN for regular before NPH. You draw up the clear regular insulin before the cloudy NPH insulin. The most critical, high-stakes topic related to type 1 is diabetic ketoacidosis, or DKA. This is a life-threatening emergency. The patient will present with severe hyperglycemia, typically over 250, cusmal respirations, which is rapid, deep breathing, a fruity odor to the breath due to ketones, and metabolic acidosis. The NCLEX will test your ability to prioritize care. Your absolute first priority is not insulin. It is fluid resuscitation to address profound dehydration. You will start a bolus of 0.9% normal saline. A common exam trap is choosing insulin as the first action. The second and equally critical step is to check the patient's potassium level before starting an insulin infusion. Insulin drives potassium out of the blood and into the cells. If the patient is already hypokalemic, starting an insulin drip can cause fatal cardiac dysrhythmias. Only after you've initiated fluids and confirmed the potassium level is stable do you begin a continuous intravenous infusion of regular insulin. Another frequently tested area is sick day management. The exam will give you a scenario about a patient with type 1 diabetes who has the flu and is not eating. The most common incorrect answer choice and the biggest trap is advising the patient to stop taking their insulin. You must instruct the patient to never stop taking their insulin, as illness and stress actually increase blood glucose levels. To help you remember these crucial instructions, use the mnemonic SICK. Is for sugar. Check blood glucose every 3 to 4 hours. I is for insulin. Continue taking your insulin as prescribed. C is for carbs. Consume liquids with carbohydrates to prevent hypoglycemia if you can't tolerate solid food. And K is for ketones. Check your urine for ketones. Knowing these priorities for DKA and sick day management is essential for preventing long-term complications like nephropathy and retinopathy and for passing your exam.